My name is Beverly Tuomola. I'm a certified heart failure specialist, and today we're going to talk about living with heart failure, medications, and therapies. In the last segment, we talked about when the body doesn't get enough oxygen-rich blood, it causes heart failure. So what is actually happening inside the body when the body doesn't get enough oxygen? We used to think of heart failure as a mechanical problem. The heart's just not able to pump, and so if we make it squeeze harder, things will get better. But back around 1985 or so, we learned that heart failure is more than just a mechanical problem. When the body doesn't get enough oxygen-rich blood, it causes activation of the neuroendocrine system. And so plasma levels of neurohormones like noradrenaline, renin, angiotensin, vasopressin, all of these things rise. Initially, it's a compensatory mechanism. It's meant to keep the patient going and keep them from feeling badly. But as these neurohormones continue to get pumped out, it becomes very detrimental to the heart function. So activation of these neurohormones will eventually lead to worsening symptoms of heart failure. The heart function continues to worsen, and these patients have a very high mortality if we don't shut the systems off. These neurohormones, or stress hormones, have the following effects. They will constrict arteries, and the tight arteries make it harder for the heart to pump against the high pressures. They make the patient retain salt and water. So fluid builds up in these tight blood vessels and eventually leaks out into the gut and the legs, which we talked about earlier today. Also, extra salt and water in the body will cause the patient to get thirsty. And this is a very difficult disease to manage because the thirst center in the brain is altered, and these people are very thirsty, and they drink a lot, and it just makes the problems worse. So as the fluid builds up, the heart works harder. So neurohormone activation continues, and what happens if we don't shut the system off, the heart will remodel. And as the heart remodels, it begins to enlarge and get big. It gets weak, and the EF eventually drops. So again, the 50% is normal, so these patients can drop into their 40s, 30s, and again, I've seen patients and treated many whose ejection fractions have dropped into the 10-15% range. Or the heart can get very stiff and relax just have a very poor relaxation phase, and symptoms continue to worsen. So early on in my career, when I first started nursing and when I was in the ICU, we would only treat patients basically with the symptoms. So we would treat their symptoms by giving them diuretics or water pills to alleviate the fluid congestion and get rid of the extra water. And then we would also give them drugs like digoxin or lanoxin, which basically help the heart squeeze and just alleviate symptoms. But we weren't stopping that cascade of neurohormonal activation. So around 1985 or late 1980s, we started using drugs called ACE inhibitors and ARBs, and then further on we started using beta blockers. And both of these drugs work in relaxing the blood vessels, decreasing the workload on the heart, and then the beta blockers eventually we found had many more benefits from that, and we'll talk about that in a moment.